There we go.
Okay. Hello. So, since we're recording this, let me say, hey, I'm Dr. Ed Weisbart. I'm the National Board Secretary of Physicians for a National Health Program. I'm a retired family physician in St. Louis, Missouri, and the topic today is really important to me. You all are parts of Students for a National Health Program, so you probably agree with me that the best way to reform healthcare is through getting to single-payer Medicare for all. What you should know is our strategy now to get there has three legs to it. The first is what we talked about last week, which is what is single payer? How does that work? What does that look like? But we have two other legs to our strategy. The second leg of that is that we believe traditional Medicare, on which we want to build that solution, is pretty flawed. So we need to make improvements to it, which we talked about last week. But the third leg of the strategy is that Medicare itself is under a profound attack, as are many other things in healthcare today, by private corporations that are basically drawing profit off of our program at the expense of actual healthcare and patients and outcomes. And we think that's on track. If we don't slow it down and stop it, it's on track to really kind of destroy the Medicare program that we want to build on instead of destroy. So we're very focused on Medicare Advantage as a thing that's been taking over Medicare. But to be clear, that doesn't mean that we suggest that everybody in the country who's on Medicare Advantage should vote with their feet and switch from Medicare Advantage to Medicare. That's not what we're suggesting because there are a lot of things built into Medicare Advantage today that make that a more nuanced decision for an individual. For a national policy, yeah, it's really clear, and we'll talk about that. But for an individual, we are not saying, you as medical students, not recommending that you go out and make your patients feel like they've made a terrible decision if they're in Medicare Advantage, because it might be the only actual decision that they can afford to make. So we'll explain what that means during this discussion. So let me show you some slides. And as I told you, I'm very slide centric. And there we are. I believe you can see them now. Yeah. Okay. So that's the topic du jour is Medicare Advantage, what you and your patients need to know. But to start this, I want to introduce you to another member of my family. You met one last week, and I have the permission of another one to introduce you to her. So this is my mother-in-law. So by show of hands, tell me if you agree that she is indeed the most beautiful mother-in-law in the country you've ever seen. Yes. Anybody who disagrees can't just, log off now. So I'm very fond of her. Unfortunately, she passed away a couple of years ago now, but there she was. And I had her permission to tell you this story in case you're worried. Um, Ma had hokum. She had hypertrophic cardiomyopathy. Used to be called hypertrophic obstructive cardiomyopathy, and I'm learning not to say the word obstructive. So she had HCM, hypertrophic cardiomyopathy, which, as you know, is uncommon. And it's frankly rare to show up well, she was in her mid 80s when it showed up. And that's frankly rare. And as you probably know, it's a usually genetically related, gradually progressive, relentless disease that in her case showed up with crushing chest pain and shortness of breath and inability to, ambulate very much and was rapidly getting worse to the point where it was pretty frightening, frankly. So Ma lived in Florida most of her life, the last 50 years or so of her life, and in Daytona Beach area. And we live in St. Louis. There is nobody in Florida, or there wasn't 10 years ago, whom we could find, no physician in Florida whom we could find that had really any expertise and experience at treating hokum, especially an onset in a geriatric population. And the treatment is an alcohol ablation of your coronary artery, the septal arteries in your the arteries in your coronary cardiac septum. Sorry, I'm hurrying too much. So a septal artery ablation, that's pretty dangerous. You got to do that right. Basically, we had to give her a heart attack. You want to do that right. You want somebody experienced. And if there was nobody in Florida, as there was not, who could, with that experience, we looked around the country for people with experience. And it turns out there are three centers in the country that focus on this, on hokum and seniors. And St. Louis is one of them, Washington University. So, hooray, it was easier then. So we flew Ma from Florida to St. Louis. She spent most of a week in the hospital recovering from the heart attack we chose to give her, and then spent a few weeks recovering at our house after that, and then went home. And that was, maybe 10 years before she passed away. And in the intervening time, she had two major orthopedic surgeries, which she couldn't have had. She was probably had just a few months left had she not had the procedure. So she did great. It never actually recurred, and she was fine. She passed from something completely unrelated to that. So hooray! Why am I telling you this? What does this have to do with anything? Because Ma had Medicare. I had what I call traditional Medicare. A lot of people call it traditional Medicare. Some people call that original Medicare. So if you're confused by people calling it traditional Medicare and then there's this other thing called original Medicare, don't let that confuse you. These are synonyms. They are the exact same thing. Why there's two terms, I don't know, but they're synonyms, and they both refer to the original form of Medicare created in 1965, which had basically two parts. Part A for inpatient things, and Part B largely for outpatient things. That's Part A and Part B of traditional Medicare. When I say traditional Medicare, I am referring to Parts A and Parts B. I am not referring to Part C, which is Medicare Advantage, and we will talk more about that. She also had Medigap, which is a Medicare supplemental policy that took care of the co-insurance and the deductibles for the most part. So we'll talk about that more too. But she had traditional Medicare and Medigap. And as a result of that, she could go to literally any hospital in the country, to almost any doctor in the country. I believe 1% of adult medicine physicians, refuse to accept Medicare. The other 99% of us do accept Medicare. We don't all accept new Medicare patients because we don't all accept new patients, but pretty much any doctor or hospital in the country with traditional Medicare, she could go and see. And she, I think I might have mentioned this to you before. I'm the logistics person in the family, so I arranged all this. I never called Medicare or anyone for permission. Didn't have to get prior approval for this $100,000 worth of care. Her doctors ordered it. We wanted her to have it, and whammo, she got it with no insurance company barriers, and she didn't pay a penny. She didn't. She pays her premiums for her Medigap and for Part B, but she didn't pay a penny for this procedure, this big expensive deal. And then after when she went home, she didn't have any surprises. A lot of people with commercial insurance will have surprise bills show up because their anesthesiologist or radiologist are not in network or whatever. They'll have surprise bills show up months after they've gotten their care. And that didn't happen to her at all. So she loved it. She loved her traditional Medicare, and she trusted. It turned out to be a justified trust. She trusted that it would be there for the rest of her life. So if you wanted to mess with her Medicare, you would have to deal with this facial expression, which I have. And trust me, you didn't want to have to deal with the other things that went along with that. So how does this work? What is the difference here? So first, let's unpack traditional Medicare. And as you can see on the card, that means Part A and Part B. So it's pretty simple. It's almost like this cartoon, Americans pay our taxes, and then the federal government, when we turn 65, or a few other circumstances, mails us our Medicare card, and then patients take that to see their physician or go to the hospital, show them the card, and then the physician or hospital bills Medicare, CMS, the Centers for Medicare and Medicaid Services, and they bill Medicare. What Medicare doesn't pay, then we bill the supplemental policy for, and it's almost as simple as this cartoon. Not quite, but almost. So it works brilliantly. That is not how Medicare Advantage works. Medicare Advantage is so different from traditional Medicare that there's actually a bill being proposed in Congress that says that they shouldn't be able to use the word Medicare in their name. It's like not Medicare. And there's also people who refuse to call it Medicare Advantage because that implies the advantages all go to the patient. And that's not clearly the case. Somewhat, but not at all so clear. So there's folks who call it Medicare Disadvantage. I don't know. I call it Medicare Advantage because that's just the name of the thing. But there's beware that that's a value-laden term to call it Medicare Advantage. So how does it work? So instead of having the simple cartoon, now you see these commercial, generally for-profit insurance companies interposed between Medicare and physicians. And so how that works is that the government prepays the insurance companies on the behalf of patients. So if an insurance company has a patient signed up with them, then every month or every quarter, I don't know really how often, Medicare pays in advance to the insurance company before any healthcare has actually even been delivered. And then the insurance company, of course, is expected to pay physicians and hospitals once the bills come in. So, first thing you can notice is that they're prepaid, which means that the money is in their bank account. So from their point of view, the insurance company's point of view, that's their money at that point, and they're not eager to let go of it. So they actually call the amount they spend on healthcare a medical loss. And the percentage that they spend on healthcare actual expenses, they call that the medical loss ratio. So they don't want to let go of it. So they have tactics and gambits to hang on to it. One of which is to complicate my little cartoon. They, of course, don't want patients to go to just any doctor. They tell you can go to this doctor, not that doctor, and this hospital, not that hospital, because they negotiate rates to get to the cheapest deal that they can. They say they also negotiate for high quality, but that's hardly clear when Mayo Clinic just dropped out of most Medicare Advantage networks. So they mainly negotiate on price, and they direct people to the least expensive and not necessarily the highest quality hospital. So it's quite different from the traditional Medicare cartoon that I showed you. And the most striking thing, of course, is the narrower networks, fewer physicians. And indeed, something like 12 million people who are in Medicare Advantage are excluded from seeing the vast majority of the physicians in their county. So, why are we paying an insurance company to tell us which doctors and hospitals we can't use? But that is what we're doing. This also where you start to get the HMO type tools, like prior authorizations and other things, which are almost completely absent, almost from traditional Medicare, but they are universal almost in Medicare Advantage. They are prepaid, so the healthier somebody is, the more likely they are to be able to retain that prepayment. So they have a bunch of strategies to attract healthier people, and they're not quite as invested, so to speak, in attracting sicker people. They have an astonishing degree of overhead and profits. Traditional, well, we'll show you that in a moment. I have some numbers on that. And then the last thing is because of all the gambits that they do, we believe they are paid as much as 35% more per person than the same people would cost in traditional Medicare. And that added up to $140 billion in the year 2022. And if you're like me, you're thinking 140 billion. Yeah, but it's the federal government. Is that like a big number? I don't know. Well, remember, the federal government is shut down right now because of a fight over $1 trillion over a decade. So 140 billion over a year, simplest math would be 1.4 trillion over a decade. So we are overpaying the insurance companies by vastly more than was enough to literally shut down the federal government over a fight. So it's a lot. Yes, it is a lot of money that we are overpaying to them. So let's make the difference a little bit more clear because it's probably the most important thing to understand is the difference between Medicare and Medicare Advantage. And I'm going to unpack a bit of what I referenced about my mother-in-law, Medigap, because she did have that. She did not have Plan G. She had Plan F, which is no longer being sold. So we will not talk about it very much. But she had but I will talk about Plan G. I believe that's the most common one. Medigap policies are actually arranged A through N, whatever number of the alphabet that is. There are that many styles of Medigap. If your patients are overwhelmed by that variety, tell them to go to Plan G. For most people, that's the right choice, and I think of it as G for good to remember it. Go to pick a Plan G. There's G for good, and if they don't like the price of that, there is actually a high deductible Plan G in most states, but G for good. So let's compare the differences between among these three things. So first, traditional Medicare, as we've said, almost every doctor and hospital in the country, but you have to pay 20% of all outpatient care. So that's called a coinsurance. 20% copay is a flat dollar amount, like a $10 copay. Coinsurance means you get the approved bill and then you pay 20% of whatever the approved amount is. So that's coinsurance versus copay. So in traditional Medicare, there is a 20% coinsurance for outpatient care, and there is for next year a deductible that's been increased to $1,716 every time you're hospitalized for as many as three hospitalizations per year. So think about that. If you're hospitalized, let's say once, that's already more than most people have access to financially. If you're hospitalized three times, that's a lot of money. 20% coinsurance once a month, once a year to a doctor, big deal. 20% coinsurance for biweekly visits. It's pretty expensive to be in traditional Medicare, and there's no limit to how high that can go. These are flaws. These aren't features that we want to have maintained. These are flaws. So there's no limit how much that adds up to. Traditional Medicare does not cover hearing. It does not cover eyeglasses. It does not cover dentistry. And it doesn't include a pharmacy benefit at all. Inpatient pharmacy, yes, but no outpatient pharmacy. Hospital or medical office infused drugs, that's part of Part B. But retail pharmacy drugs, yeah, no, there's none of that in traditional Medicare. And that's what Medicare Part D is. You go and you buy Medicare Part D from a typically for-profit insurance company, and then you have outpatient pharmacy experience. But traditional Medicare does not include hearing, vision, dentistry, or a pharmacy benefit. And so for these reasons, most people, 90% of people in traditional Medicare, one way or another, get Medigap, and in addition, get purchase a pharmacy benefit privately. So Medigap is sold by typically for-profit insurance companies. It's not sold by the federal government, although it is regulated, and most people get that. A lot of folks get it from their employer. Some folks get it from their union, but the most common thing is to buy Medigap if you choose to go into traditional Medicare. It's not cheap. Medigap policies are about $2,000 a year. Part D is about another $700 a year. That's 2025. We don't know 2026 yet. So that's, $2,700 a year. For a lot of Americans, that is a major decision factor. But if you want traditional Medicare, it's probably a good idea to get Medigap. So if you get Medigap, then you have an out-of-pocket maximum of $257 in 2025. It'll probably be a little bit higher next year, but after you've paid $257, that might be just a piece of one hospitalization. That might be a couple, three office visits where you paid your 20% coinsurance. But after your total out-of-pocket expense for covered benefits hits $257, you're done. You're paying your premiums, but you're done paying for actual care at that point. So yeah, I'd hit that a long time ago. I have traditional Medicare and a Plan G supplement, and after like February, I'd paid my deductible or my 257, my out-of-pocket maximum, and since then, for the rest of the year, I go to see physician whenever I want to, and I come and I go, and I don't pay them anything, and it's like I'm a European. I mean, it's just like wonderful, So anyway, there's that. Eliminates most of the out-of-pocket expenses, but it does not. Medigap does not add hearing, vision, or dentistry. But like I said, it's not cheap. And here's a trick. Here's a factoid that 98% of Americans don't know. And it's really an important factoid. So if there's one thing you take out of this that you take home, that you remember, that you can tell your patients about, here it is. So we all think, because it's true, that the ACA prevented insurance companies from applying pre-existing conditions when they sell us a policy, and that's like, hooray, so they can't send you a health survey questionnaire. They can't ask you if you've had cancer. They can't look at your chart. They can't ask you your drugs. They can't do any of that. If you apply for a healthcare policy through the ACA marketplaces, the insurance company has to sell you a policy at the same price they would charge anybody. Nice. The same thing, that law, that protection does not apply to Medigap. That protection disappears in Medicare. There's a different, similar protection in Medicare. So for Medicare, there's a law before the ACA that says if you want to buy Medigap, the insurance companies have to sell you a policy at the same price they sell it to anybody. They can't send you a health survey questionnaire. It's called guaranteed issue. They're guaranteed to sell you a policy, and it's called community rating, the same price they sell it to anybody else. Guaranteed issue community rating, not from the ACA, separate law. But that protection disappears after you've been in traditional Medicare, Part B specifically, for 6 months, or Medicare Advantage for 12 months. It's extended to 12 months for Medicare Advantage. So if you've been in Medicare Advantage for 13 months or 366 days, and you run into some of these problems that I'm going to be walking you through, and you think, well, I saved my Medigap premium for 5 years because I was healthy, I didn't have any problems, I didn't really care about all that stuff, but now I'm sick. Now the insurance company won't let me go to the yada yada place I want to go to. I'm going to go and get into traditional Medicare next time open enrollment comes. You can always do that. You can always switch during open enrollment from Medicare Advantage back to traditional Medicare. You can do that. But there's no guarantee after 6 months in Part B or 12 months in Medicare Advantage, there's no guarantee that the insurance companies will sell you a policy for Medigap at all, let alone at a price you can afford. So they almost always send you a health survey questionnaire and jack up your price based on your own personal health condition, if they'll sell it to you at all. So that's the trick. Your patients who can afford Medigap, and not everybody can, it's not cheap. Your patients who can afford Medigap, who think they're being clever by waiting until they're sick enough to need Medigap, they need to know the pros and cons of that decision. It's an arithmetic problem, but it's a real problem. Medicare Advantage, as I said, is completely different. So first of all, I think the average premium in 2025 was $20, I think that it was. Here in Missouri, it's zero. There's a lot you can get into Medicare Advantage for free in Missouri. The average is about $20 a month. So that's a big difference. You don't have to spend the $2,700 on premiums that you do if you're in traditional Medicare. You just no premium for Medicare Advantage. And it includes stuff. It comes with stuff. It comes with a pharmacy benefit. They all come with a pharmacy benefit. Almost all of them come with hearing and hearing aids and vision, eyeglasses and dentistry and a range of things. And we'll unpack that a little bit more. It's nowhere near as generous as they might make you think, but it does come with extra stuff. So that's nice. And in theory, the law says they have to require everything that traditional Medicare covers. So if traditional Medicare covers, the cardiac ablation of an alcohol of a septal arterial, Medicare Advantage does too. So in theory, they have to cover everything that Medicare covers. But they are allowed to make up their own rules about what is medically necessary. They don't have to disclose these rules. They don't have to align them with the national consensus guidelines from, the National Cancer. They don't have to do any of that. They can make up their own rules that they don't have to disclose about what they decide is medically necessary, and they get to review whatever they decide they want to review, and they can have AI do the review. If it's a denial, the AI review has to be issued by a healthcare provider. It can't be issued by the AI machine. But healthcare providers that are working in this environment have reported that they get handed a stack of 100 recommended denials and that they sign off on that 100 recommended denials in like an hour or less. So they don't spend much time on it. And the person reviewing it does not have to be a physician. It has to be a healthcare provider and does not have to be a physician in the specialty that's relevant. So, I mean, literally any healthcare provider can be issuing the denial. So, secret rules, undisclosed, not aligned with national consensus guidelines. In theory, the Medicare Advantage corporations have to cover everything that traditional Medicare does, but I'm here to tell you that's not the case, and I'll show you what that means. They're all different. Traditional Medigaps are all the same. If you get a Plan G, you got a Plan G, and you got a Plan G. All the Plan Gs have the same design, the same copays, the same everything. Medicare Advantage, every stinking one is different. So it's really tricky how to pick one for yourself. And we'll talk about that a bit. They are statutorily required to put an out-of-pocket maximum of about $10,000. I should probably look that up again. I don't remember the exact number, but about $10,000 a year out-of-pocket maximum. I mean, that's like bankruptcyville still. It's pretty high. The majority of Medicare Advantage plans actually on the market sell a product that has a $5,000 out-of-pocket maximum for in-network care. So it's not as high, but at $5,000. You can't buy Medigap. You're not allowed to buy Medigap if you're in Medicare Advantage. So that's a difference. Medigap, $257, and your out-of-pocket is done. Medicare Advantage, your out-of-pocket can go up to $5,000. So, or more, depending on which product you join. So that's a whole lot of stuff. Nobody's brain is big enough to really think about this. So what most people do is they think about traditional Medicare. I don't want nobody telling me I can't go to such and such doctor or hospital. That's what draws people in. But the downside, I want that, but bankruptcy. And so, and it doesn't have this stuff, and can I afford to buy Medigap? So that's how people sum up traditional Medicare. Medigap, they love, the no out of pocket after they do that, but the price is a big, big deal. Medicare Advantage, people are drawn in by instead of $2,700 of premiums, no premium. That's nice and extra benefits, and this maximum on out of pocket. So not quite as desperate a need for a Medicare supplemental policy. That's how people decide this. Um, so one of the things that's pretty interesting is as we've been talking to Congress about our concerns about Medicare Advantage, it's grossly overpaid, and it's as we've alluded to, and it's got some other problems with actual clinical care, as I've alluded to. Every time we've talked to members of Congress about it, the pushback is that the insurance industry, that's AHIP, America's Health Insurance Plans, is what it used to stand for. Now I think it's more like KFC. It doesn't stand for anything, but we all know it's the insurance industry lobbying group or advocacy organization. So AHIP goes to Congress and says, you can't touch Medicare Advantage. We are a vital source for low income and diverse populations. And they point to this kind of data that, and this is true, they're not lying when they say this. They seldom lie. They just grossly misrepresent, but they seldom lie. So this is true that people of color are indeed significantly more likely to choose or to wind up in Medicare Advantage than are white enrollees. So, but does that mean, is that proof? Is diversity equity? Is diversity equity? Is that really how this works? No, it's not. More is not better. Diversity does not equal equity. So think of this. So diversity applied to subprime mortgages. People of color were a lot more likely to buy subprime mortgages. Diversity applied to payday loans, still does. And indeed, these are predatory products. These are not equitable products. So the claim that diversity equals equity just doesn't apply for sure. So I would argue it doesn't apply here either. We've been studying this for many years. So our first report from 2 years ago showed that Medicare Advantage is profoundly overpaid. And we showed you this. We're not the only ones citing numbers of this order of magnitude, but it's a lot of extra money that they're getting. And then we said, but it's not just extra money, they're actually hurting people. So the next year, we went to Congress with this report saying Medicare Advantage is causing harm. And Congress said, but it's equity. Equity is the solution. This is the solution to equity. And we said, no, it's hurting people. We said any plan that hurts people can't be a solution to injustice. That's not how arithmetic works. And they said, well, equity, look at the diversity. That's equity. No. So we've spent the last several months producing this report that we just released a week ago, I think, maybe something like that, looking specifically at the issue of equity and Medicare Advantage. And we think the right name to call the report is No Real Choices. So we will explain that a little bit. First, as I've said now many times already, diversity is not equity. And the proof, we partnered with Johns Hopkins researchers and found that indeed people of color are being disproportionately enrolled in the lowest quality plans. And they have no choice but to go into Medicare Advantage because of what we call the gap trap. They can't afford Medigap, as we've talked about, and so they get trapped. So they have to do this, and we call that the gap trap. And the claims from the insurance industry that they give better health outcomes are just hollow. The reason that we call them hollow is because we've looked at dozens of the bits of literature that they produce, claiming that there's better outcomes in Medicare Advantage than there is in traditional Medicare. And one of the ways the insurance companies get overpaid for the patients, as we alluded to here. One of the ways they do that is they claim to have sicker patients to begin with, and so they've persuaded Medicare that if their patients are sicker, they should get more money. So their prepayment rates go up if they have sicker patients. The determination that patients are sicker is by how many diagnostic codes are entered when we see patients, or if a nurse reviews the patients or whatever. So that's called upcoding. They have a tremendous, multi-billion dollar, tens of billions of dollars reward for upcoding, for adding diagnoses that we otherwise didn't think were needed in the chart. We code what we think we need for taking care of the patients. The MA companies make tens of billions of dollars by upcoding. That's pretty well recognized these days in Congress, this upcoding gambit that drives up their prepayments. What's not recognized yet, and we're hoping to change with this report, is that almost all of the literature that the insurance industry produces compares the outcomes of upcoded healthier people in Medicare Advantage with real coded sicker people in traditional Medicare. And guess what? The upcoded healthier people in Medicare Advantage have better health outcomes than the sicker, not upcoded people in traditional Medicare. Almost all of their literature is riddled with that mistake. So when you see something suggesting that they have better outcomes, take a good look at the methodology section and see if they corrected for upcoding. Most of it does not even mention upcoding, and the ones that do mention on upcoding usually have in the very fine print in the methodology disclaimer caveats at the end that we tried to adjust for upcoding, but we know we didn't do a good job at it. So upcoding really confounds their claims. So there's that. So we looked at these plans, and I told you that the MA plans are lower quality. How did we come to that? Well, it turns out that 25% of Medicare Advantage plans have a high enrollment among people of color. They're not just distributed randomly. It's particularly a quarter of Medicare Advantage plans that have more people of color than the demographics of that community would predict. So they're concentrated. So we looked at that, and the insurance industry says, well, that's a good thing because we want them there so that we can really be sure we're delivering the specialized extra care that people from these disenfranchised communities need. So they say that's a good thing. So we said, okay, well, if that's the case, we should shut up and go home. So let's look at that a little bit. So we did. And we used Medicare as a tool for assessing whether a Medicare Advantage plan is good or bad. They score it. It's called a quality star rating, and they can score it anywhere from 0 to 5 stars each plan. And so the star ratings, the score for the star ratings, is what we use to tell good from bad. It's Medicare's tool. We didn't make it up. And it's a useful tool. It's imperfect. But it's the best there is. So it measures, how well does the plan drive cancer screening? How well is the control of a variety of illnesses? How well is care coordinated in all these kinds of ways? And what's customer service? How quickly do they do appeals of a prior authorization denial? And a whole range of things that are actually relevant to patients. They're very relevant to the insurance companies because if they can hit at least 4 stars out of 5, they get more payments. They get more money. They get to keep more. There's a whole bunch of things, including bonuses that they get to keep. So if they hit at least 4 stars, their prepayments go up, and they get an extra bonus for at least 4 stars. Oh man, I screwed up that build. Sorry, I really messed that up. Sorry. Told you you're getting new stuff. That's an example of a new stuff. So it turns out that the score difference is really important, and it's not the same for black and white and other people of color. So we stratified where the spread is around the 4.0 threshold because, it's starting at 4, they get higher prepayments and they get bonuses. So the 4 is the important part. That's why this chart doesn't go down to 0 and doesn't go up to 5. The 4.0 is the threshold. That's really part of the decision. So it turns out that the plans that have higher than you would expect enrollment of white enrollees, they're safely in the higher paid threshold. It's not true for people of color. People of color are in plans that are below this threshold. Why would that be? Why would that be? Is it because they're poor shoppers? Is it because people of color don't know how to buy a good product? No, that's not it. Matter of fact, to disprove that, insulting speculation. In the few communities where people of color are offered 5.0 star plans, they are more likely to pick the 5.0 star plan than are white enrollees in Medicare Advantage. So, no, it's not shopping experience. It's because the higher quality plans are not offered in those communities. Why would that be? Because they don't have to offer them. Because remember, folks that have less wealth can't afford Medigap and can't escape Medicare Advantage. So the insurance companies know that they're not competing against traditional Medicare, they're competing against other Medicare Advantage plans. The people in Medicare Advantage are trapped there. We call it the gap trap. They can't afford Medigap. They're trapped in Medicare Advantage. So the insurance companies know that, and they have very little reason to sell the higher quality plans. And by higher quality, that means less egregious activities. That means less prior authorizations. So the plans that people of color are trapped in are more like they're not just trapped in Medicare Advantage, they're trapped in the plans with the most egregious prior authorization plans and all these other things that drive their star rating down. And the insurance companies do that for a business imperative because they can make more money by these aggressive things. So the bump up from the quality thresholds and these things I was talking to, I just assume we don't have this data, but I assume that that's less valuable than the money the insurance companies can make by being more egregious in this way. They just don't care about it. So that's what we mean by the gap trap. Medigap makes the price makes traditional Medicare unaffordable, specifically for people of color. The insurance companies know that, and so they know they're not competing against traditional Medicare for people of color nearly as much. And as a result, that enables them to administer lower quality plans, and it facilitates all of these things that they can get away with to maximize their profits because you can't escape them. You can't. So it's we call it the gap trap, and it explains a lot of the ways that Medicare Advantage maintains and actually exacerbates inequities. And it's really true that they do. If you look specifically at people in fair or poor health, in other words, at people who need health insurance, if you look at people specifically in fair or poor health, everybody in Medicare has trouble accessing healthcare due to the cost of healthcare. So people in Medicare, in traditional Medicare, even with Medigap, about a quarter of them will tell you that they have difficulty accessing healthcare because of financial barriers, even in traditional Medicare with Medigap. 25% of white enrollees, 27% of blacks. Awful, unacceptable, but the same. So equitable. Awful, but equitable. In Medicare Advantage for white enrollees, it's significantly worse. It goes from 25 to 35% of people say they have financial barriers. And man, for African American, for black enrollees, it goes to 50%. 50% of black enrollees in Medicare Advantage, 50% of black enrollees in Medicare Advantage who are in fair or poor health report difficulties accessing care due to the cost of care. That's not equity. When Medicare Advantage says their solution to equity, look at this chart. That's just not what that means. That's not what that means. And really, everybody in Medicare Advantage has trouble accessing with medical bills and medical debt. So, across all incomes, people in Medicare Advantage have more bills and more medical debt. Lower income, it's worse, but a little more equitable, maybe because Medicaid eligibility might mitigate that somewhat. People of medium income is where it's the most striking between traditional Medicare and Medicare Advantage. And then when you look at wealthy people, guess what? They don't have so many problems with medical bills or medical debt because they're wealthy, defined as more than $40,000 a year for a family of two in 2024. So not terribly wealthy, but wealthier. But it's a big deal for everybody. So I said that Medicare Advantage attracts people because they have extra benefits, and you see all these on the TV machine. What I'd like you to notice is that things like bathroom safety down the bottom, not too common, because who wants to join a plan that has bathroom safety? Somebody sicker. Who wants to join a plan that offers gym clubs, which I didn't put on the chart? Oh yeah, no, fitness, yeah. Somebody who's healthier. Nobody on Home O2 from COPD gives a hoot about a fitness center. So these are somewhat designed as marketing tools. So let's look at how much they actually deliver. We're not going to unpack all of them. We'll look at these three because I think those are the biggest three for people deciding, oh, I'm gonna go into MA. I saw the ads on TV. They said I could get a dentist. So let's look specifically at that. So, dental visits, how much is it worth? How much do you save if you're in Medicare Advantage when you go to the dentist compared to if you're in traditional Medicare, most of whom don't have dental insurance? You don't save very much. You don't save very much. The dental insurance in Medicare Advantage is worth something, and this is an average. This is national data. This is an average across all MA companies. So your results may vary. You may find a plan that has a more generous dental benefit, but the average around the country is pretty limited. Pretty limited. How can that be? How can it be this limited? Because it's just not very good insurance. It's not even insurance. They don't call it dental insurance. They call it a dental benefit. Turns out to be an important legal distinction. So the dental benefit in Medicare Advantage typically has relatively few dentists. People would have to drive 2 hours to get to a dentist for whom they could get a lower fee. They don't do that because that's got an expense too. They don't want to spend the time on that. So most people have this dental benefit from Medicare Advantage, and yet they just think, well, I struck out on that one. I'm going to pay out of pocket. Well, that means that the value goes down on the average visit. The benefit most commonly stops at about $1,000 a year. I dare you to get endodontia for $1,000. Some plans are more generous. I've seen some plans that go as high as $4,000 a year, but the average, the most common, not the average, the most common is to stop at $1,000 a year expense. And other than preventive work, you typically have to pay half of the cost. That adds up, especially if the benefit stops at $1,000 a year. And then there's these crazy like one tooth rules and two tooth weightings, and there's a whole host of bizarre, arcane dental rules that nobody can possibly know when they're choosing their Medicare Advantage plan based on wanting a dental benefit. But there's a whole bunch of stuff. So it's complicated. And at the end of the day, at the end of the chase, the Medicare Advantage dental benefit typically is worth a lot less than people think listening to the ads on television. Similar things, I won't unpack them, eyeglasses, similar sets of things that show the eyeglasses are typically not, you don't save nearly as much as you might think. And I've called this hearing aids, but actually it's general durable medical equipment in the study. They called it hearing aids too, but they rolled in other durable medical events. So the dollar amounts are a lot lower than you would think for hearing aids, but that's because it's not just hearing aids in the average. But the value is indeed strikingly limited. So it's not as much of a benefit. I'm going to skip that for time. So then you have to get approval for things. And virtually everything that costs more than $1.73, I made that number up, not really, they require their approval for and it's a problem. They deny the claims more frequently for people of color. Isn't that nice of them? So white enrollees, 15% denials for their prior authorizations, and black enrollees, it shoots up to 23% denials. And I don't think this means that there's some, evil racist medical director sitting in the Medicare Advantage claims office saying, "Oh, this guy's black. No way you've given him that." I don't think that's this at all. I think these numbers reflect the fact that people of color are compelled to use the lowest quality Medicare Advantage options, which have the most egregious prior authorization policies. But this is just another manifestation of how it confounds things. And this is getting worse, the prior authorization system. The most recent data I have shows that they are now at nearly two prior authorizations per enrollee per year. Nearly two. That's again an average. So some people won't run into any. Some people, somebody who wants to stay in a skilled nursing facility for rehab or something, they may have to get prior authorized every 5 days. So there's a huge variation in this, but the average is two per person per almost two per person per year. That's a lot, especially when you compare it to traditional Medicare, where it's like almost never done. Traditional Medicare requires prior authorizations for, I think, like 6 or 8 different things. There are things that seem pretty reasonable to me, like blepharoplasty. I mean, some people need a blepharoplasty because their lids are so low that they actually have obstructed vision. Yeah, that's medical. But most people who want a blepharoplasty just want it for cosmetic reasons. So the prior authorization for blepharoplasty in traditional Medicare is just wanting documentation that it's for visual field defects and not for cosmetic purposes. So they do some prior authorizations, and I think that's probably fine, but it's pretty rare. It's extremely rare. And as I showed you, that's one of the reasons people choose traditional Medicare. Well, you may not have noticed, but Dr. Oz, the head of CMS, is actually a licensed insurance broker for Medicare Advantage. The HHS, the head, or CMS, the head of CMS. I think he may have given those up when he joined, when he took this job on, but I'm not sure about that. But for sure, before that, he was a licensed insurance broker for Medicare Advantage, and now he's the head of Medicare. So the idea of growing traditional Medicare as we want to is not one of his goals. Instead, his department is about to unleash this new thing called Wiser, wasteful and inappropriate service reduction. So a new program, brand new. It's going to start January 1st, 2026, unless we successfully stop it, which we are trying to. But it'll start probably, I don't know if we'll win or not. Start January 2026, and they're going to rapidly and grossly increase the number of prior authorizations in traditional Medicare. So it's starting in those 6 states. It's starting with like a dozen or 17 or something specific procedures that they think are justified to do it with. It's gonna not ha it's gonna have it's not gonna use the same mechanism that the blepharoplasty. There's a whole mechanism. There's a group called a MAC. There's a thing that traditional Medicare uses for the ones that they do that are really appropriate. It's efficient, it's effective, relatively low turnout or denial or reversal rates on appeal. It's a really pretty well done thing. Wiser, the model they're proposing, is completely different. They're not using the existing program in traditional Medicare. They're proposing AI companies. They're proposing having different information, different agencies, the same agencies that often do prior authorization reviews for Medicare Advantage, which have a very high reversal rate on appeal of their denials, so they're grossly inaccurate and they're just profit centric. They're going to use those companies to do the prior authorization reviews for traditional Medicare. They're specifically soliciting the ones that use the most AI and machine learning to do this stuff. And wait for it, get this. They're going to get a bounty for every blocked service. They're going to these are bounty hunters. Every time this Wiser outfit says no to a traditional Medicare service, they're going to get paid for that. They're not getting paid for the review. They're getting paid for saying no. If they don't say no, they don't get any money. They're bounty hunters. So they're introducing that, and that's going to completely erode one of the two or three most important things that makes me and a lot of other people choose traditional Medicare. That's a great strategy, Dr. Oz, smart guy. Dreadful. So we are part of what we are feverishly working on at PNHP is to stop this. And we have a pathway to stop it. We're trying to chase that down, and involves Congress. But involves Congress. So we can talk more about that if you want. But we are hopeful that we can kill it. This is all sort of theoretic, but it's not theoretic at all. So if you look at cancer patients and compare traditional Medicare versus Medicare Advantage, these prior authorizations delay care. They delay care. And so, before we had this high penetration of Medicare Advantage, oncologists or oncologic surgeons used to measure their quality by the time from diagnosis to definitive care. And they would often try to make sure that they had the definitive surgery done within 5 days, if it was a surgical thing. They don't even measure that as a goal anymore, because now it's typically 4 to 6 weeks or 8 weeks because of all the delays that the insurance companies introduce. So these prior authorizations that delay care have transformed practice guidelines because you can't possibly do it as well as you used to be able to do it. And so in this study, you can see that people waiting for definitive care for cancer had to wait. And delaying care for cancer changes your stage, changes maybe the treatment approach, and certainly changes your chance of a cure. So delaying care is not a good thing, and that's rampant in Medicare Advantage compared to traditional Medicare. And people in Medicare Advantage seldom get access to places of excellence. They seldom get to go to a National Cancer Institute designated cancer center. Well, gall darn it, I don't want to pay an insurance company to tell me that I can't go to the best places in the country. That's not right. Most people, as you can see from this chart, most people don't go to the NCI centers because they aren't in their neighborhood. And most people make the decision, yeah, that might be better, but this place is probably good enough. And, if I needed a Whipple's procedure, I'm going to a place that knows how to do Whipple's procedures. But, most people make that decision of logistics too. And so But in Medicare Advantage, they're not making a decision. They can't go to a center of excellence. Is this all important? I mean, so delayed care, you go to less experienced, less expert care, is this important? Yeah, it's really darned important. Mortality, post-operative mortality rate in Medicare Advantage for these same diagnoses is significantly higher in most of these categories. So, yeah, they're killing people. They're literally killing people by delaying care and redirecting people to the worst places. So that's a big deal. And they're getting paid way extra to do this. And that makes me angry. And they lie about it. Here's a report from the Senate a couple of years ago looking at how much they lie about it. And I'll just point out that the Senate points out that all these ads that we're now seeing again on TV, they're not Medicare. All of these ads, they're not Medicare. They lie to us. They look like they're Medicare. There's a bill in Congress that will keep them from doing this, but who knows if it'll pass. But they do lie, and we'll show you how to tell which ones are Medicare, but these are not. And then so insurance agents, are just as bad. So about a third of people deciding between Medicare and Medicare Advantage turn to an insurance broker. So an agent works for a company. A broker handles lots of companies. So an insurance broker, they all say this. They all say, "Hey, come to me. I sell all these plans. I sell all the Medicare Advantages. I sell all the Medicaps, Medicare supplements. Medicare. I do all that stuff. I am a neutral third party. I will sit down with you. We will figure out what your needs are. I've got this computer that'll help us match that with what the plans all offer because it's confusing. They're all different, like I said. So we will, come and sit down with me. I'll give you an unbiased guidance so you can get the right plan for you. That's important. I care about you, buddy. Is that true? Are they unbiased? Well, follow the money. Follow the money. If they can get you to sign up for Medicare Advantage, they make almost $700 next year. If instead you only sign up for Medigap, they make half that. That's the definition of biased, not the definition of unbiased. And then if you then say you go through all that with them, and then you decide, well, I need to get a Part D now, what they will typically tell you is, we just did all this stuff on Medicare Advantage and Medigap. You can just go to Medicare.gov. You're probably tired. Just go home, go to Medicare.gov, and you can shop for your own Part D. It's really easy. It's great. The Medicare Part D, that's really easy. Just go there and shop for that. I'm here to tell you, shopping for Medicare Part D is way more difficult. You got to figure out which drugs you're on next year. You got to figure out, it's really complicated. Finding the drug list for the Part D plan is not easy. Finding out, do they prior authorize that drug? I mean, it's really hard to shop for a Part D plan. There's all kinds of things in it. The reason the brokers won't talk to you about a Part D plan is because they don't want to. It's not a good use of their time. They make a lot more money if they can go to the next client and sell them on a Medicare Advantage plan. So they make a lot more money, and then they keep making the money. Every year that you don't change brokers or change Medicare Advantage plans, they get a renewal fee for you forever. They keep making money as long as you don't change. They keep making money off of you, and above these commissions, there's a whole range of other services that the insurance companies pay the brokers for, data collection and a whole bunch of other things that they do. So the insurance companies know this. I went to the National Contracting Center, which is the place where insurance brokers are trained. And here's their website. And they so right on their homepage, retire on your Medicare renewals. If you want to retire on your renewals, insurance broker, you can't do it selling life insurance. You have to sell Medicare. And if you have 500 clients when you retire, for the rest of your life, it'll fade as people die, but you can get $150,000 a year for many years to come just from your Medicare sales that you're no longer doing anything for. So they know this. They're not unbiased. It's their plan. So the thing you need to know about all this for your patients is that there are a couple reliable sources. The first is this. It's called the State Health Insurance Assistance Program. It's a terrible name. SHIP or shiphelp.org. That's the QR code if you want to capture it. But shiphelp.org. Remember that this exists. This is in every state. Each one is different, but every state federally funded to administer a handful of staff, and then it's mainly staffed with volunteers from the community who have no conflicts of interest. They're just volunteers to help people pick between Medicare Advantage and which Medicare Advantage or traditional Medicare, which Medigap. That's all they do. They're just there. They're not paid. They're not conflicted, and they just want to help you. You can go to their website and set up a one-on-one in-person counseling session. And there, I know several people who do this volunteer work, and they're great. They will be unbiased. That also means they stay within the parameters of what Medicare says they can say. And that's, I think, kind of biased towards the insurance industry. They won't tell you any of the stuff I just told you about death rates. They won't tell you that stuff. But they will not give you just straight Medicare Advantage marketing noise. It's relatively good source. So SHIP Help, State Health Insurance Assistance Programs. Or if you don't want to do it in person, if you want to do it on the phone, you can go to Medicare. The Medicare.gov website, the insurance brokers were right. It is a terrific website. It's like eBay or Amazon or Travelocity. I mean, it's really good. It's amazing how good it is. So you can go there and it's easy to navigate, big fonts, and simple questions to get you to what you need. So Medicare.gov, really, really awesome website. Or if you're not computer friendly, call Medicare. And it's a hard number to remember. It's call Medicare, 1-800-Medicare. That's the only phone number that gets you to Medicare. Call 1-800-Medicare. Yes, that's 8 letters, so the E doesn't really matter. But call 1-800-Medicare. And I have not done this since this in 2025. I've not called them under the new administration, so maybe it's not true. But until now, in pre-Doge, I think it might still be okay, but certainly pre-Doge, if you would call that number, they would answer quickly. I've called them dozens of times. They answer quickly. You can almost hear the person smiling when you talk to them. They listen carefully to what you say. They give you substantive, accurate answers to what you ask about. They can compare things for you. If they don't have the answer, they'll go get somebody. My advice to people when they call, though, is that you are calling a call center, and you can call dozens of times and get good people, but probably once in a while you'll get somebody who sounds like they either don't know anything, or they're not smiling, or they won't listen, or they're giving you stuff that just doesn't make sense. So they're probably just having a bad day, and I'd say just nicely hang up and call right back. And you're in a call center, you'll get somebody else. And the vast majority of people you get are like spectacular, or they were pre-Doge. I don't know, they might still be, but it's a terrific. So Medicare.gov or 1-800-Medicare or shiphelp.org, and everything else is malarkey. Everything else is malarkey.